Welcome to our video on pulmonary antimicrobials. Often this subject can be a little bit sort of info dumpy, in which they throw a bunch of conditions and a bunch of drugs at you, and it's all very confusing. So what we've tried to do with this one is we've tried to group it into a few main categories. So first of all, I'm going to go through all the drugs, and these are all common antibiotics that are on your core drug list, and are really good to know in general. And then I'm going to go through some of the main, not main conditions, but the more light or less threatening conditions that we can treat with those drugs. And then we'll go through a few more special cases in which we have specific drugs or specific treatment that we want to go through. So let's get stuck into it. All right, so these are our antibiotics. Again, looks like a lot of information, but I want to draw your attention to probably the second column here, type. The drug names are important, and of course you'll need to recognize them when it comes to MCQs and stuff. But really what we want to teach you here is the different classes of drugs, because within a class, drugs have the same mode of action and pretty similar adverse effects and contraindications. So penicillins, like amoxicillin, which is probably our most common drug, we have inhibition of cell wall synthesis, so it prevents us from bacteria, from putting together their cell walls. We can pair it with beta-lactamase inhibitors, like clavulanate, and those basically just further help with preventing the bacterial cell wall from being formed. Now, because we're preventing something as integral as a cell wall from forming, usually these are bactericidal, so they kill bacteria, they don't just inhibit them, okay? Which is good for us in some cases, not so good in other cases. Now, these are pretty well tolerated, which is why penicillins are still more or less our drug of choice. Sometimes you get nausea and diarrhea, and you'll notice that sort of GI disturbances are a pretty common theme with antibiotics. Okay, and of course you want to check for penicillin allergies, which are not uncommon. And so a lot of the time we sort of end up shunting patients onto a different thing. Often our next category, which are cephalosporins, cephalosporins. Now you'll notice a lot of them have names that start with kef, like a drug of choice here, cefuroxime, in the same way that most penicillins end in cillin. Now these guys also inhibit cell wall synthesis, and as such, they will also be bactericidal. So they kill bacteria. These ones are a little bit less well tolerated, which is why we usually want to put someone on amoxicillin or penicillin in general, if we can do it. So we get GI disturbances, we get opportunistic infections because we're killing off normal flora. If we have a really rare case and the patient is particularly unlucky, there may be neurotoxicity, which might lead to head and neck pathologies, and sometimes spinal pathologies. We do want to watch out for patients' renal function, because this is a drug which is renally cleared. And so if the patient has impaired renal function, then they may not be able to effectively get it out of their system, which is a bad thing. Now, tetracyclines, you may know these are a little bit infamous because of one of the contraindications, specifically children under 8. So one of their effects is calcium chelation, which means that we get discolored enamel of the teeth and decreased bone growth, both of which are quite bad for children. So you might see photos of children with sort of really blackened and weird looking teeth. That comes from tetracyclines. So doxycycline is our one of choice. And of course, we want to make sure that that choice is not for children under 8, or for pregnant women, or for people with bad livers, because it requires metabolism in the liver. And if that is impaired, then we can either damage it further, because hepatotoxicity and impaired renal function may be potential adverse effects of this drug, but it may also result in unwanted metabolic effects. So these guys are bacteriostatic. They inhibit protein translation at the ribosomes, which means that they don't necessarily kill the cell immediately. So again, surprise, surprise, we have gastric symptoms. We have the aforementioned calcium chelation, and we also have photosensitivity. So if you're on one of these, you usually want to avoid necessarily staying out in the sun too long. Okay. Our next group here is the macrolides, erythromycin and azithromycin. So again, pharmacologists can be very helpful with their naming schemes, and if you see a mycin, usually it's going to be a macrolide. These guys are also bacteriostatic because they don't mess with the cell wall or anything as central as that, and they mess instead with protein synthesis. Again, classic culprits, GI symptoms and opportunistic infections. Now, sometimes we have some fun stuff, ototoxicity, which means it messes with your ear, or cardiac problems. Specifically, we tend to get ventricular cardiac arrhythmia. So ventricular tachycardia, ventricular fibrillation, Torsades de Pointes, that sort of stuff, and classically QT prolongation. So you get a really wide sort of wave there on the ECG, and those can all be quite bad. So we want to be careful about which drugs the patient is also on, and watch for family history of the patient themselves, but also the dosage and the use of the drug and how well it's tolerated. Okay, that was a lot of information. Now we're going to apply some of it here. So rhinosinusitis, this is your classic, your nose is inflamed, your sinuses are inflamed. A lot of people get this all the time. A lot of people are fine, okay? So we would only want to treat if it's acute rhinosinusitis and we've got really severe symptoms for more than 7 days. And you can find those sort of severe symptom those severe symptoms criteria in various sorts of therapeutic guidelines. If it's chronic rhinosinusitis, so some people have this sort of low level all the time, usually that's also fine. We might have some treatment for that, again, mostly symptomatic, so trying to relieve the symptoms the patient is experiencing. If they get purulent discharge, so pus basically, then we want to put them on antibiotics. Okay, so symptomatically, acute, we want to get rid of something for the inflammation in general, which is NSAIDs. And if those aren't working particularly well, then we may turn to decongestants. And the ones that we use, typically the way that they work is that they actually constrict blood vessels in the nose. And as we know, inflammation, a really big part of that is vasodilation. And by reversing that, we can go a long way to reducing it. For chronic rhinosinusitis, if you've watched the aspirin COPD lecture, you might know about inhaled corticosteroids, and that's what we usually use there. Sometimes we might use an antibacterial with them, or sometimes we might use it by itself. Now, if we have indications for antibacterial therapy, then we would usually use amoxicillin. If it's not working so well, we might add clavulanate. If they're allergic, then we would shunt them over to ceftriaxone or doxycycline. So pharyngitis and tonsillitis, we're now moving from sort of the nose and the sinuses to the throat or the upper throat. So sometimes it's viral, in which case you usually just wait for it to self-resolve. If it is non-viral, then we might be worried, especially if it's caused by something like strep pyogenes or Haemophilus influenzae. So for the treatment is usually focused on pyogenes because that's the one that we're more concerned about, because it can lead to a lot of dangerous complications like quinsy. And so usually we treat it using narrow spectrum penicillin, so benzyl penicillin, not on your core drug list, that one. If we are allergic to penicillins, then we shove them over to cefalexin, which is a type of cephalosporin, or azithromycin, which is a macrolide. Okay, otitis media, we're sort of doing a tour of ENT at the moment. This is going to be your ear. So if we don't have any of those criteria, if we don't have really bad disease basically, or they're not high risk, then we're just going to treat it with Panadol basically. But if they are high risk or they have severe symptoms, then we're going to put them on amoxicillin and so give them a cephalosporin, of which cefuroxime is on your core drug list, and cefaclor is not. Sorry, I cannot speak today. Bronchitis, lots of people get bronchitis, lots of people are fine. If it's viral or if it's mild bacterial, then we usually just sort of let them get over it basically with some bed rest, fluid, that sort of stuff. Always a good idea. Now, if we are worried that they might be infected by whooping cough, so Bordella pertussis is a causative organism for that one. And we're particularly worried about people who are in their last month of pregnancy, babies who are under 6 months old, or basically under 2-year-old, really small toddlers who are unvaccinated. So if they're, usually you get your vaccination for around 6 months. If you don't, then we need to keep you on prophylaxis for longer, or you may get it. So whooping cough is really bad. And that means that when we do have a suspicion of it, or if we're trying to protect against it, we have a macrolide therapy, which is fairly strong, that we want to really make sure that we avoid it. All right. Okay, so getting on to some more serious infections. Now, obviously the previous ones, if you get complications, they can be quite bad. But these ones in the right patients can be quite bad on their own. So influenza, again, most people get it, most people are fine. For the ones that are high risk, so immunocompromised, they have already forms of respiratory distress, that sort of stuff. Then usually we use antivirals, and we actually use a specific type which is made specifically for influenza, and they are what we call neuraminidase inhibitors. So neuraminidase, as the name suggests, is an enzyme that viruses, influenza viruses in particular, produce, and they use it to cut a little bridge between the host cell and the viral particle in order to let the viral particle go and infect more cells after it's infected one cell. So when we inhibit neuraminidase, it can't cut that link, and so it just sort of sits stuck there to the outside of the cell, where it can be more easily addressed by your own immune system and where it can't infect other cells. So the two main drugs that we use for neuraminidase inhibiting are oseltamivir and zanamivir, and they both have the same method of action and not too many adverse effects that you need to know about. So pneumonia, and this is basically going over community-acquired pneumonia, which is the more common type. Hospital-acquired pneumonia, you guys don't need to know too much about, and has a slightly different treatment regime. So in terms of mild pneumonia, you just chuck them on some of the normal ones, so amoxicillin, penicillin, or tetracycline, doxycycline. If it's moderate, you might add those together. So we use a narrow spectrum penicillin like benzyl penicillin plus doxycycline. And if it gets really bad, you use something like ceftriaxone and azithromycin. All right. So TB is really, really bad in particular patients, especially those with risk factors. And it is usually caused by a particular organism, Mycobacterium tuberculosis. Now, this is a special type of bacteria which has a different form of cell wall, and so it's not actually as susceptible to normal guys like doxycycline or amoxicillin or ceftriaxone even. And so we need to use a particular type of combination therapy known as RIPE. So our first one is rifampicin, which messes with RNA polymerase in Mycobacterium tuberculosis. That one, we want to be careful with what other drugs we're giving it, because if patients have certain prescriptions, it can interact poorly with them. Isoniazid is another one. And so that one deals with cell wall synthesis. Now, because it's a different cell wall, this one doesn't work so well for non-TB stuff, and other bacteria, like we said before, don't work particularly well for TB. This one has a bit more of a sort of not aggressive, but poor adverse effect profile. So we may get allergies, we may get fever, we may get hepatotoxicity, which can be bad with other drugs. So again, this is sort of we want to be careful with what combinations we're giving people. If they're already on some sort of drug, which is hepatically cleared, so you need your liver to be functioning for it to work properly, and you put them on isoniazid and they get liver complications, and then that can obviously be a bad time. And sometimes you get hematological issues with that one too. Pyrazinamide and ethambutol aren't as big as the first two, but they're still important. So you may get a risk of gout, gastric upsets, because it wouldn't be a proper antibiotic therapy without them, and some normal sort of fever and malaise. Ethambutol is another one which messes with specifically the TB type of cell wall synthesis, and you may get a really fun condition called optic neuritis, which is where your optic nerve gets inflamed. Now, usually these guys are only used as part of combination therapy for TB, and that is both because in the case of some of them like rifampicin, if you used it by yourself, you develop resistance really quickly, and so it would just it would work a little bit and then it would stop working because now all the bacteria are resistant. For some of them like isoniazid and ethambutol, because they are messing with specifically the type of cell wall used in TB, which is sort of made of a type of acid called mycolic acids, hence the name, they don't work so well for other bacteria. So we typically only use these 4 drugs as TB drugs. And so you rarely see them outside of that context. Okay, so that was a lot of information. Hopefully you've soaked some of it in. Obviously the slides will be up, and I encourage you to look back through this video in order to revise. We don't expect you to get it straight away. That would be ridiculous, because there's a lot of rote learning involved here. But stick with it. Try and maybe approach it in a systematic way where you think about the drug classes and how they work and the implications of that. So why you might want to use a macrolide, which is only bacteriostatic, instead of something which is bactericidal, and thinking about the ways in which you can identify a drug. So many of them, like penicillins, doxycyclines, macrolides, and cephalosporins, they will all be pretty easily identifiable if you know what to look for in their names. So keep an eye out for those. Awesome. I'll leave it there. See you guys next week.